It's my great pleasure to introduce Dr. Luba Frank, my friend, who is, I think you're now, you're an associate professor of radiology and you're at UTMB, right?
No, yeah, I'm at Baylor College of Medicine, and I'll put the slide out because I keep moving, so so the Lord.
Okay, I
So,
was there. You've have worked in a few institutions, so I noticed that you had moved around a little bit. So thanks for correcting me. But super excited to relaunch our Curious Cases webinars, which um, were launched a few years ago by NASCI, and we they somehow fell a little bit on the wayside. They were not as quite as well organized as we could have been, and so we have given this to our education committee headed by Jonathan Revels, who has graciously and incredibly done a really great job in combination with another committee. Jonathan, are you able to speak? Or Luba?
Oh yeah. Okay, let me see.
So it's two committees.
There.
Am I correct?
Hi. Yeah,
Hi.
so it's through myself and through the Electronic Communications Committee, and
Perfect.
yeah, and so we're
Perfect.
super excited to get this all revamped for everyone.
Yeah, and I know it's going to be a real success because it's in your hands, and Dr. Frank is going to give us the first session today. This is meant to be very educational, and I think we'll have some time for questions, and I really hope that everyone will find it educational and beneficial. And as president of NASCI, I'm really proud that this has gotten off the ground again. So thanks again, and off you
Thank you very
go,
much.
Uba.
so yeah, as we said, we really want to have this session to be interactive, to be fun. These are just cases that we are showing. Those cases meant to be educational, but also bread and butter, but just a little more fun for you guys to look at. Really we do want to have this interactive session. So I might ask someone's opinion, and if someone wants to take a case, especially now when the radiology board review format is going back to kind of hot seat or oral exam. This is a really good example, or really good chance to practice a little your interpretation skills, and and see the interesting cases as well. So let me share my screen. I hope that will work out. Bear with me. Okay. All right, do you guys see that the first slide? Please do tell. NASCI Curious
Yes,
Cases webinar,
Yeah.
September 4th.
all good.
Yay.
Yay.
Yes. So I just want to make sure that I see everyone as well. If someone is trying to um, raise a hand, we have a chat option. Do we have a chat option? I don't see the chat option, but we do have the raise my hand option, so you guys are welcome to do that as well. I'm going to minimize this, and then we're gonna start the presentation, or our session. So I'm Dr. Frank. I work at the Department of Radiology at Baylor College of Medicine and Baylor St. Luke's Medical Center at Texas Medical Center in Houston. It's been a lot of fun. I just started here less than a year ago, mainly doing lots of hearts and coronaries and some other things. So I will show you a few cases that I thought were interested in. There's some of them really hot off of the press. There's some of them we just saw a few weeks ago, maybe last week. So um, this is my first case number one, and that's a case of a 36-year-old female with the chest pain and suspected coronary artery disease. She came with elevated troponins and really persistent chest pain. So really, unfortunately, I cannot show you, cannot scroll through the images and cannot show you any scenes. But I chose those static images that are best and representative of the pathology. So, and I really wanted to hear if any trainees are online or someone really wants to take it and participate in that. Is there anyone who is really brave today or feeling brave today? And let's say maybe Brian.
Hi, Dr. Frank. Yeah, I can try.
Okay, let's do this.
So I think this, just looking on the CT image on the far right, so it seems like a very short left main, but otherwise looks pretty. I don't see significant disease. Maybe in the ostial left main there is mild soft plaque, but nothing too significant. And then in the LAD itself, I think in like the mid LAD, I do see some mixed plaque there, like a calcified plus soft plaque. A bit hard to quantify, like the degree of stenosis, but it looks at least intermediate.
So would you think that there's a stenosis in the LAD? What we describe?
So again, looking at the image on the far right, in the mid LAD, I think there is calcified plus soft plaque. It's a mixed plaque.
Right. So what he's saying is the expansion of the size of the vessel, right? So the vessel is dilated compared to the proximal portion of it, and it looks a little bit irregular, and there's a soft tissue component associated with that dilation, right? So, but if you look closer, and again, I apologize, I cannot rotate it or scroll through, but if you look closer, so this is LAD, left main coronary artery, and then again, that's covered reformats, and that's more or less an axial view that I could create. So you could see that focal area, the small plaque, but there you also see this linear hypodensity in the proximal and mid LAD that extends throughout the artery, and it appears that it looks like a dissection flap, right? So in a patient who is 36-year-old young female with a chest pain and the findings looking like that, with in addition, do you see any calcium or any signs of additional coronary artery disease? Not really, right? All based on the limited images. So what do you think we're looking at? So we're looking at the linear hypodensity within the LAD in the young female.
I think it's probably SCAD, spontaneous coronary artery.
Yeah, exactly. So when I see that the chat is popping up, also a dissection, that is absolutely correct. This patient, this is a case of spontaneous coronary artery dissection. This is CAD. Here we go. So this was approximately 4.2 centimeter long. That is a really long coronary artery dissection in the proximal mid LAD, and then ending at the distal LAD. So this patient ended up going for a cabbage, as you can see on this 3D image. Right here, partially imaged. There's the limit to the LAD, and then the distal LAD is vitally patent. That's the treatment that this patient received. However, not necessarily, depends on the severity of the case. That it could be just a watchful management, with the follow-up examination. Any questions on that, or any other? Any other?
Hey, Luba, Jacob here. How are you?
Good. Who is this?
Jacob Kirsch.
Oh, Jacob, hi, how are you?
Good. It's a
Yeah. So
beautiful, beautiful,
what do you
no, beautiful case. And beautiful. I have never seen scat this long before. So I was one, not just you, but everybody on the chat. Has anybody seen something like this? And or do we have any? Does the patient have any collagen vascular disorder or anything, any underlying, anything that could, like, I'm trying to figure out
think?
how to
No. Yeah.
explain it.
No, that we know of. Not that we know of. So she came already with the diagnosis because she had some workup done at an outside institution. So all I have here in it Texas Heart here that we did this coronary CTA and then we have it. To the best of my knowledge, no, she doesn't. And we did look into everything. We looked into it, and then I have this they have this a little discussion about the SCAD and the importance of determination of what we're looking at, because the differential diagnosis here is, atherosclerosis and Takotsubo and coronary embolism and coronary spasm as well. So, and as you said, that there was risk factors of fibromuscular dysplasia, collagen vascular diseases, inflammatory systemic disease, including IBD, actually, inflammatory bowel diseases, and hypothyroidism and pregnancy emotional stressors. Not really, she did not have this particular patient. She didn't have, or maybe we were not able to extract pertinent information, but not that we know of. Yeah, I thought that this is the terrific case to show. Usually we're looking into that, trying to find those dissections, but this one, really, you don't have to work so hard. So, are we good to go to the next one? So what I wanted to show you, a few cases, or actually 3 cases that are very similar or relatively similar in appearance, and specifically pertinent to that concept of spontaneous coronary artery dissection. So it is defined as the acute development of a false lumen, or basically dissection. And the second, and this is not secondary to atherosclerotic disease, or not because of the aortic dissection, not iatrogenic or related to trauma, and that's what basically spontaneous coronary artery dissection means. So the other case that I wanted to show you is also a middle-aged female. She's 59 years old, and she came actually as an outpatient. She came with the history of VT, hypertension. She's got some palpitations, some chest pain. And while she was working, she's got a couple episodes, and symptoms were concerning for ischemia or arrhythmia. So she was sent to the coronary CTA as an outpatient, actually. So, and looking at that case, you can see. So if someone wants to take it, please do. I'm happy to hear what you guys have to say. Is anyone brave enough, or we're just gonna show and tell? We could do show and tell as well. No hands? Okay. So, looking at the 3D image of the heart, you can see that those coronary arteries are pretty tortuous, relatively large caliber, but really not too bad. In patients with hypertension, you'd expect something like this. Those are torches. The LED looks pristine, looks very nice. The calcium scoring was was 0. There was no calcium in the coronary arteries. The circ was fine too. But I noticed all those tortuosity of the medial and distal portion of the arteries, and then if we could rotate that, I'd show you that all arteries and all branches are actually tortuous. Now, looking at the RCA here, you can see a really focal area and some oblique area of stenosis here in the mid RCA, and I believe I have a little better. Yeah, so in the mid RCA right here. So there's no disease in the proximal. There's no disease in the distal RCA as well. And then here, that's a curved reformat, and this is a cross-section view through that lesion, and this lesion looks near complete obstruction, occlusion of the vessel with a little bit of associated fast stranding surrounding the lesion, but really not that much of expansion of the lumen or really nothing else. It's really abrupt. So we read it as a severe stenosis up to 99%. That's pretty much, we could probably give it a categorized 5 as well. The question here was about, well, are we looking at SCAD again, or are we looking at the atherosclerotic disease? In addition, for that lesion, we did the FFRCT as well, that there's a perfect correlation of the FFRCT with the really tight stenosis here, the huge delta between the proximal and distal segments of this stenosis, and then the flow calculator or model 0.54, and then if we took it even lower, that probably would have been even lower, which corresponds to severe focal stenosis with reduction of flow. So this patient went to, let me see, this patient went to cath lab. And the message that we received from the cath lab was that this was a plaque and with near complete stenosis. The stent was placed, and patient was doing well. So I wanted to show you what the SCAD looks like and what the atherosclerotic plaque looks like, even though in this particular case it's a little bit difficult to tell a difference between two of them, but then the cath lab decided toward the plaque. So any questions about that case or comments?
Nice, nice case, Luba. This is Shaima. This patient does not look like having any calcifications or calcified plaques. Is that correct?
Yeah, absolutely. And that was the reason that so when I read that case, I said, you know what, I really worry about SCAD in that particular case as well, because no atherosclerotic disease torches coronary arteries, well, no calcium, torches coronary arteries, female, middle-aged female, and then, you know, we should think about SCAD as well, but it turned out not to. Was that your question?
Yes, it's tricky. Like lipoprotein A can be elevated in patients and has been linked to non-calcified atheromatous plaques. So it can happen that you can have like non-atheromatous plaques and with zero calcium. With this CAD, the only thing is I would expect it to be a little bit longer segment. That's the only hint that might be, but I would call it the same thing. Either stenosis or SCAD.
Either stenosis or SCAD, exactly.
Stenosis or from plaque, non-calcified plaque or SCAD.
Right. That was our differential as well. So I thought that this is something to show you guys the variety, or not the variety, but the spectrum of the findings that we can see in the coronary arteries that are similar or looking similar, but you know, can be classified as SCAD or not. So and then another case that I wanted to show you again, another companion case. It's a different patient, a patient who came with a chest pain, and wanted to show you. This is not SCAD as well, because, well, this one really I wanted to ask someone from the trainees if anyone is available. I don't want to put Brian on the hot chair every time, but if there's anyone else wants to participate in the discussion, please go ahead. So this patient has known severe atherosclerotic disease, as you can see, but this patient also has known dissection or hematomal dissection that extends from the aortic root into the proximal RCA right here. So here's in the cross-section view, and you can see how expanded that lumen is. Well, not the lumen, but the wall is literally showing hematoma surrounding the lumen. This patient, I might have mistaken, but to the best of my knowledge, this patient didn't have instrumentation, and this is basically a dissection that was diagnosed, that was detected, and the patient was transferred to the CT a couple of days later for the follow-up to see what's going on with the RCA. after this dissection was diagnosed at the coronary cath. So those three cases, I thought that would be a terrific comparison. What is SCAD and what is not particularly considered as SCAD. So any comments on that one?
Dr. Frank, so in that middle image, is that a cross-sectional view of the osteal RCA?
Yes, that is correct. So it's somewhere here, cross-sectional view of the osteal RCA. All right, guys. So we can move on to the next case if. All right. So the next case, so we have a patient, very complicated patient, really, with the known coronary artery disease, post-infralateral STEMI, with stents, HFrEF, very low ejection fraction, ischemic cardiomyopathy, everything is known. I wanted to call on a trainee, or could do show and tell. What do we see on this scout view from a CT? So we did do a CT to evaluate left ventricular assist device and looking for the pump thrombosis. And particularly wanted to ask what type of LVAD is this? Do you have anyone brave enough or not?
I can try again, Dr.
Okay.
Frank.
So what do we see? Can
Okay,
you
on
call
X-ray,
the,
sure, yeah.
Yeah,
So
can
I mean,
you call the device?
Yeah. So you mean all the artifacts on the X-ray, right?
Yeah, that's a scout view from a CT, but yeah.
Sure, yes. So I mean, the view I have the X-ray, the AP, and the lateral view. So you see an ICD there. I think it's a single chamber. Let me see. Single chamber ICD, and then we see sternotomy wires there, and then we can see atrial clip right, on the left side of the lumbar spine. And then we see, like you said, an LVAD.
So
I'm
what
guessing
type
it's
of
probably
LVAD is that? Can you tell me which one?
it's probably a HeartMate 3.
Okay. So, why do you think that's HeartMate? Well, that's correct. That's correct. So, why do you think it's HeartMate 3?
I mean, just going by probability. I mean, I think these days we don't really do HeartMate 2 anymore, or HVAD. So I'm just guessing it's HeartMate 3.
Right. Okay. So the inflow cannula, outflow cannula, right? So, and then the drive line. So the reason I'm showing you this is, to make sure that you do look at the scout views as well, because on the scout views often where sometimes we can see the broken leads, we can see the abandoned leads, we can see some displaced leads, or any abnormality or kink of the drive line. And that's important as well. This patient had the abdominal pain around the drive line, so that this was a part of the evaluation why he was sent to ACT. So, and then just wanted to refresh the knowledge that you already have about what the components of the HeartMate 3 and why does it look like that, because it is important to also see the location or position of the device as well to make sure that it's not displaced. That is precisely where it's supposed to be. So we have this inflow cannula that takes blood from the left ventricle, the motor, and with the rotor with internal magnet and the pump chamber. And so we have this outflow cannula that goes to the aorta, and then here you can see it here. And then this one is not radiopaque, so we don't really see it here. All we see is just a little shoulder or a little cannula. So that is indeed a HeartMate 3, and then that was well positioned. Now when we looked at the cross-sectional images, and then I made some recons or like 3Ds for you guys as well. So really did not see much of a of a thrombus. Very often you see this hypoattenuating material that is abutting or lining the walls of the outflow cannula, but overall the cannula was widely patent. The connection is great and beautiful. We can see that this heart is the left ventricle markedly dilated. There's very abnormal, but really there's a significant artifact here, but after multiple manipulations with the images, we did not see thrombus within the cannula. And here is the 3D image just to show you the physiology of the device. Now I'm going to move to the next one, and I want you to tell me what you see on this one, because these all three images are abnormal. So what do you think? We have on the very left, we have a non-contrast or pre-contrast series, and then arterial phase, and this one is a reconstructed image. What do you guys think? Is there anything abnormal? And then if you want me to go forward, I could do that too. That's fine with you.
Hey, this is Ty, but I could see on the image on the right, it looks like there's a kind of a filling defect at the anastomosis site of the outflow cannula and the ascending aorta. The left image and the middle image, I'm not, well, you could kind of, no, yeah, I'm not too sure, but there's definitely something abnormal on the right image.
Okay, so let's start with this one then, okay? So what do we see on this? This is non-contrast slice. So this is a slice of non-contrast CT. What do we see here, right? So this is aortic root, this is RCA, right? So we're seeing here right heart and left heart. This is the RVOT, probably right atrium. This is probably a left atrium right here, right? That's basically the same image that we're seeing here. So what do you think is this? Remember, that is non-contrast study, right?
Yeah, sorry, I don't know. I can't see if you're pointing at anything.
Oh, you cannot see
I
my
can't.
mouth? Oh, okay.
Yeah, no, I can't. I personally can't see it. Pointer.
Hey, this is Tim from University of Kentucky. I'm one of the trainees here. It almost looks like an intramural hematoma in the non-con.
Okay, it says in the, why do you say, why do you think so?
It's hyperdense on the
Exactly.
non-con. It's right at the,
yeah, we have a hyperdense sign, so there is it looks like that there is a blood somewhere there. However, if we were looking at the intramural hematoma, we would be looking at more of a crescentic appearance of it, but you're on the right way. So, but then, you know, you have some help here on the right side. You guys don't see my mouse at all, so how can I?
Yeah, we can't see your mouse, unfortunately.
Okay, so how do we? Okay. Is there a pointer or something that is available? Well, we just will have to.
Yeah, I think you can mention the image on the right and the image on the left. I think we can like get it.
Right. So so let's do a little bit differently. So we have this focal area, relatively well demarcated area that occupies mostly the right coronary cusp, and it appears hyperdense, and it appears confined by the borders of the cusp itself, right? So, and that is pre-contrast imaging. On post-contrast imaging, we have this very similar appearance of the lesion, but this area is hypodense, and again confined by to the right coronary cusp. This very similar thing we see on these reconstructed sagittal oblique image right here. So what we have here is a hyperdense sign. There's a large thrombus within the right coronary cusp. And this large thrombus occludes complete occlusion of the RCA, ostium of the RCA, and the entire RCA as well. So this is the case of the thrombosis of the aortic root, as we sometimes or pretty rarely see in the left jugular assist devices. So this case is a representation of the aortic root thrombosis in patients supported with continuous flow LVADs. So it happens approximately 22 days plus minus following the implantation of the devices. More common is involvement actually of the non-coronary cusp, but that also results in RV failure. But in this particular case that we have, this is the thrombosis of the right coronary cusp. The survival is affected. The incidence of MACE is higher in these cases as well. So the 1 and 2 years survival is 73.8 and 44.3% respectively. And of course, we're talking about a higher rate of complications. We're talking about strokes. We're talking about myocardial infarctions, etc. So not many cases were published. Actually, a couple of cases, and one of those that I referenced down here was actually coming from Texas Children's Heart Institute, and then I think that the Texas Heart Institute published another case a while ago, also with the review of the literature as well. So here you go. One more time, look at this. Remember about this type of abnormality as well. I thought that was a really cool case to show you. So any comments, any questions about this one?
Hi, this is Francisco from University of Ottawa. I'm just curious about how this patient was treated.
So this patient was an anticoagulation therapy and actually did better. The problem with this patient was that it was a very complicated patient with multiple comorbidities. They could not get onto further surgery, and it just really was treated medically. Well, the patient is still alive. We did the follow-up examination. The thrombus in the aortic root and the right coronary cusp was gone, but the RCA was still occluded. So this is, in the follow-up study we did approximately 2 to 3 weeks after the initiation of the therapy. Did I answer the question?
Yeah, thank you. I was just curious because I had read that there was maybe a role of surgical excision of the thrombus, but
right. So this patient is very tough patient. Now he would not tolerate. The patient had cirrhosis with really a lot of multiple comorbidities that we just the surgery, open heart surgery, was not possible. And in fact, the follow-up study was done also as a CTA because they didn't really want to deal with any interventional procedures really. All right. So moving on. Let's see. So case 5 that I have, again, very complicated patient, 64-year-old male with a past medical history of non-ischemic cardiomyopathy with a low ejection fraction. He's got idiopathic VT, he's got ICD, then tricuspid valve endocarditis, and all the good stuff that you can read on that in this history report. So this patient got CMR. On the CMR, we saw that the left ventricle was okay, but there was mild systolic dysfunction. Left ventricular ejection fraction was a little bit decreased. And then I wanted to look at the MRI of this patient. Again, I apologize for not being able to show you CNA images, but here you go. This is the patient. This is the MRI. Those are black blood images, mostly T1 and T2s without fat sat. But really look at those images and see if you can come up with something that is grossly abnormal. I am very excited about that case because this is a relatively rare case, and then I'd like someone maybe to try and dive into it. Any brave souls? All right, so we're looking at the axial images, short axis, and those the coronal images as well. So those are not that sad, but the left ventricle looks okay. The gross abnormality that really jumps out and that really very prominent is that the size and contour of the right ventricle is very abnormal, right? So we're looking at the right ventricle that has very irregular border, that has some outpouchings and little like small aneurysms along the entire free wall of the right ventricle. And not only that, it actually goes along the right ventricle, extends almost into the AV groove and then apex. And those little outpouchings, it's like a little accordion everywhere. And then on the scene images, remember this patient has ICD, and it was really difficult to perform this study, better quality study. So I apologize for the image quality, but this is the study is diagnostic. And very exciting as well. So we're looking at the SSFPs. This is a short axis. This is a sort of RVOT, kind of two-chamber oblique, and then this is a four-chamber view, and this is kind of axial, stack of axial images as well. So anyone who wants to elaborate on what we're seeing here, and what perhaps could be a diagnosis as well. All right, Brian,
Dr.
should
Frank,
I call
this is
you
Brian. Yeah, so I think based on your description, I mean, we see that, there's like microaneurysms, throughout the RV seems dilated, and along with the history of VT, I think this is probably ARVC.
Well, so great. That is the case of the RVC. So I'm glad that you are talking about the microaneurysms and numerous microaneurysms. Those are probably the most extensive that I've ever seen. And then I brought you this image as well to show the microaneurysm or a small aneurysm here along the septum even. So this is, I've never seen anything like that before. And then you can see this little accordion sign here, right? And then the dilation of the right ventricle as well. So, and then I'm glad that you're saying ERVC, not ERVD, which is both are correct basically, but what is the difference? Do you know ERVC and ERVD? These are the same conditions. However, why do we use term ERVC now?
I think ARVD is the old term. D stands for dysplasia, and ARVC is a newer term, cardiomyopathy. I think it's believed that dysplasia is not the etiology, so they changed the name to ARVC.
Right, the cardiomyopathy, and then does it only involve right ventricle, or do we also see that involving left ventricle as well? So arrhythmogenic right ventricular cardiomyopathy, or ARVC, but it believed to involve left ventricle often as well. So on this CMR, this is a late gadolinium enhancement, or LGE images. So we can argue that there may be just a little bit of a subendocardial enhancement. That's not really typical, very typical to ARVC. We would see the mid-myocardial or subendocardial enhancement, but then really we do see some focal enhancement here in the inferior septum at the traction or tension point here in the anterior septum maybe too, but really very well seen diffuse dilation of the right ventricle with this abnormal contour in the aneurysm, diffuse aneurysms as well. So now the right ventricle was markedly dilated and the ejection fraction was 38%. So if we are talking about diagnostic criteria for ERVC, so there are multiple, it's a very complex diagnosis, and this is diagnosis of combined clinical, genetic, and EKG and imaging as well. So we're talking about the Padua criteria, and those criteria were modified in 2020, I believe. So there are older ones were in 2010. We're still talking about the major and minor criteria for diagnosis of ERVC. Just a little bit adjustment of the volumes when we talk about the end-diastolic volumes, indexed end-diastolic volumes. So for men, if these are more than 110 ml per meter square, or for female is about 100 ml. This patient had much more than that, or ejection fraction, right ventricular ejection fraction less than 40. These are specific quantitative measures that we can address on CMR, in addition to assessment of the morphology and tissue characterization with the lipid enhancement as well. So, but again, I really wanted to show you this this table from a American College of Cardiology EP that was published in 2022, and this is kind of nicely put together what comes into the consideration to actually diagnose ERVC. So the assessment, the diagnosis, the abnormal EKG with epsilon waves as well, and for the risk stratification, really important. Evaluate for cardiac arrest and VT, and in male sex, etc. Everything that's listed here. So, and then again, this particular patient did not come to us with a known diagnosis of ERVC, but he certainly left with one. But he did have VT, and he did have the ICD placed for the prevention of the sudden cardiac death. I think that's the last slide on that one. So, any questions or any comments on this one? It's a great work, Brian. You got the diagnosis right away. All right. I think I have one more case, and it's just a little fun case to show you. This was hot off the press really from the last week. This patient came to us with a history of Takotsubo-san in 2022. She's got CVA, and she had a concern for LV mass on papillary muscle, actually at the insertion of the papillary muscle. And these are the images of her echocardiogram that was done at the outside institution. I believe that we didn't have it here, but you can see this really small, very well demarcated hyperechoic lesion that was measured 8 millimeter, I believe, and that's really near the papillary muscle. So we thought that that could be a fibroelastoma, one of the differential diagnoses. Another differential diagnosis, less likely, but still maybe on the back of our minds, a small myxomas can sit in the ventricles as well as thrombus. So it could be a thrombus because she had a history of CVA as well, really a couple of months before she came to us. We did cardiac MRI, and cardiac MRI to diagnose or to look for additional lesions and to evaluate valves, etc. We didn't really see anything on MRI. I didn't bring it to you to just show normal MRI. So the patient went on based on the echocardiography. Patient went on to have the surgery. Minimally invasive robotic surgery. So during that surgery, no mass was found, but the PFO was closed at the same time. But what happened is that the surgeon had real difficulty to introduce the wire or access through the femoral access. So the question that we got after that is what's happening and why what's happening with the abdominal vasculature, and why the surgeon could not, why the surgeon had a problem accessing the problem of the femoral access. So, and I want to show you these images. Those are combined. This is CTA that was done actually prior to the surgery, and this is an MRI that we did after. So, and then if someone has a diagnosis,
is this like May-Thurner syndrome?
That is. So this patient had a May-Thurner syndrome, and now there was really no history of DVT, but again, you know, there's May-Thurner syndrome. We came up, so actually I did call the cardiologist, and you know what, I think, first of all, I asked what side the axis was, and I was told, well, that was the left-sided axis, right? And then measured that the size of this tiny left common iliac vein was 4 millimeter max, I believe, and it was diffusely narrowed here behind the right common iliac artery, and so you can see that on this coronal images as well, and on CT it's harder to see just because, you know, there's no opacification of the IVC, and you know, in the retrospect they're all like much smaller than when we look at the study actually. But yes, this patient did end up with a diagnosis of May-Thurner, and just a short overview. What is tested is the compression of the iliac vein against the lumbar spine when overlying iliac artery results in venous insufficiency, stenosis, and obstruction. And then actually, if we go back and look at those images again, I don't believe I brought it. But this patient also had, no, you can diagnose it based on this, but this patient also had engorged and large caliber left uterine vein and in the multiple engorged veins in the left pelvis as well. So ended up suggesting that, well, that could be because of that, or it could be the pelvic congestion syndrome as well. So in May-Thurner could be asymptomatic, or it could, the patient can have a pain, swelling, skin changes in the ipsilateral lower extremity, etc. And it could be due to thrombotic or non-thrombotic, but you know, again, the patient need to be evaluated for a DVT in order to you know, to make sure that there's no thrombosis. And I think that these were all my cases for today. We went rather quickly. If anyone has more cases or have some suggestions or comments, please go ahead. We have 8 more minutes to discuss anything you guys want.
Sorry.
I was curious if you saw any LGE in the RV wall on that ARVD case or ARVC.
So these are the images of the LG. These are most representative ones, and all we saw here is this anterior and inferior septum. This is the basal mid-ventricular segment, basal segment. And then really not much, except for, you can argue, maybe a little bit subendocardial here, but it's similar to the blood pool. Really not sure. There wasn't something that we could really call, because you know, there's the RV wall is very thin, and then you'd expect maybe, you know, myocardial or transmural enhancement of this stretched or wall if there's a fibrous replacement or of the myocardium, but really we didn't. Another area of concern was here in the inferior wall, but then again, it's so close to the liver that we're not sure if that's actually real or not. But that could be a little bit of enhancement here here. You can see the mid-myocardial and kind of subepicardial enhancement along the free wall of the RV. This is a mid-ventricular segment. This is closer to the base mid-ventricular segment, and then in this grossly abnormal free wall of the right ventricle. But there was no RVOT was dilated, but was no enhancement in the RVOT.
Thank you again.
Okay.
I want to thank everyone for joining us today, and I especially want to thank Dr. Kirsch, who was the inventor of the Curious Cases webinar and spearheaded this whole thing. And I want to thank the Electronic Communications Committee and the Education Committee for picking this up and restarting it, and for Luba to show some absolutely stunning cases today. Really, really great cases. Thanks, Luba.
Absolutely. Well, thank you all for being with us, and you're welcome to come again. This Curious Cases are going to happen every month. That would be every first Wednesday of every month, and we really encourage trainees to participate as well. I really hope next month I can encourage the trainees from Texas Heart or from Baylor College of Medicine to show some cases as well, and also the guests, if you can come on and jump on the webinar, and if you have an absolutely amazing case, you can show it as well. And with that, thank you all, and have a great day.